Hello, everyone. Hope you're all doing well, staying safe, staying healthy. This will be an interesting remainder of the semester to be sure. So, the way this presentation is going to work on a conferencing format is I have myself presenting here, and then I've also attached my visual PowerPoint presentation and a handout for you to use on the test. So, probably what you're going to want to do is have on another tab the presentation open, and then you can either have me talking and the presentation side by side, or you could just have me in the background and then just only be looking at the PowerPoint side of things. I will be letting you know when to switch to the next slide as we move along, and yeah, we'll see how this goes. So, we're going to be talking about eating disorders. These are some very particularly nasty disorders. They affect roughly 30 million people per year worldwide, and they are the most lethal type of mental illness, often leading to death by starvation. It's some really nasty stuff, and so we're going to look at it from a multitude of perspectives and see what we can't do to remedy this situation kind of on a large scale. So, I'm going to be covering the second half of the chapter, focused more on the causes of eating disorders and the possible treatments for them. The first half of the chapter was talking more about just describing these disorders and their incidence rates, things like that. So, on slide number 2, we can do a quick recap of those. We have three big players in this game. We have anorexia nervosa, bulimia nervosa, and binge eating disorder. Anorexia is going to be a disorder marked by the pursuit of extreme thinness and by extreme loss of weight. Bulimia is going to be marked by frequent eating binges that are followed by forced vomiting or other extreme compensatory behaviors to avoid gaining weight. And this is also sometimes known as binge purge syndrome. And then binge eating disorder is going to be very similar to bulimia nervosa, but without compensatory behaviors. So it's going to be only eating binges and then not doing anything about it. So this often leads to weight gain in affected individuals. So with that kind of summary and recap out of the way, we're going to be looking at what causes eating disorders on slide 3 now. One thing I want to kind of introduce before we really get into it. For my activity, I'm going to be having something you can do kind of at home in the comfort of your own home as you watch this. What I want you to do is get some kind of a snack food, preferably not like your favorite snack food, because it might not be your favorite for long. Something with a distinct taste, so maybe like Red Hots or jelly beans, something like that. If you can get your hands on something like that that's small, you can eat a lot of pieces of, you're going to want to get that. And throughout the rest of this presentation, whenever I say the word the, so T-H-E, the, whenever you hear me say that word, or if you'd prefer, whenever you see it on the slide, I want you to eat one of those. So you may end up going through quite a few of them, but we'll see if you have enough first of all, and then we'll after the end of my presentation we'll kind of revisit that and I'll explain what kind of that's all about. So, beginning to look at what causes eating disorders, we're going to be looking at a multitude of different factors. There are many things that can cause an eating disorder to develop in an individual. There are psychodynamic, cognitive, biological, social, many factors. So one thing that professionals are going to use to kind of assess all of these different risks is going to be something called a multidimensional risk assessment or risk perspective. So this is going to be on slide 4 now. A multidimensional risk perspective is a theory that identifies several different kinds of risk factors that are thought to combine to produce a disorder. So it's going to be looking at all aspects of an individual's life, and by looking at all these different factors, you can kind of develop an idea of how at risk somebody is for developing the disorder. And as well, it kind of helps develop a theory of how all of this really plays out and combines into an eating disorder on like a very deep level. So first of all, the first factor we're going to be looking at on slide 5 are psychodynamic factors, specifically with regard to ego deficiencies. So psychologist Hilda Bruch developed a largely psychodynamic theory of eating disorders. She was kind of the first in this game. She described that mother-child interactions, disturbed reactions, or just poor relationship with mother and child can lead to deficiencies of ego, and this would end up in a poor sense of independence and control in the child once they'd grown up. These deficiencies may lead to the perceptual disturbances that produce disordered eating in these disorders. And so this is going to be looking basically at parenting style and how effective parents are in assessing and managing their children's needs. So effective parents are going to accurately, they're going to understand what their child needs. If their child is crying, they'd know, oh, this is because they're hungry, I'm going to feed them, or oh, they're just cranky, they need attention, so I'm going to comfort them. Whereas an ineffective parent might fail to recognize all the signs, and they may misinterpret these. So they may feed a child when they're not hungry, just cranky, or they may just try to comfort a child when they're hungry. And this kind of behavior may mess up the behavioral learning things behind, appropriate eating behavior in the child as they grow. So this just might lead to a child not really understanding how to deal with their own needs or feelings. Many patients with eating disorders have trouble describing their feelings very accurately, so this may play into it a good deal. So that's definitely something to look at. It's very deeply rooted, being psychodynamic. So this may be something that puts somebody at severe risk for a eating disorder later on in life. So moving on to slide number 6, we have cognitive factors. So cognitive theorists believe that individuals with an eating disorder judge themselves exclusively by their weight and or appearance. Without taking into effect anything else, they have to control their weight and appearance. They feel like that's everything. That's how they're defined, is their weight and appearance. And cognitive theorists call this the core pathology of an eating disorder. This is going to be the problem at the root of everything that kind of causes everything else. Well, not necessarily causes, because it's not clear whether this is a cause or an effect of an eating disorder. Regardless, this is something that has to be overcome in all eating disorders, is getting past this body image issue inside of things. So nonetheless, it is a very important part of this, and it's important to look for that when trying to diagnose or screen for eating disorders. Another important thing to note is that many people with eating disorders, particularly bulimia nervosa, experience symptoms of depression. And this finding has led some to believe that depressive disorders kind of set the stage for eating disorders, or again, they may be more of a result of the stress caused by an eating disorder. They have found, however, that family members of those with eating disorders have a higher chance of also possessing an eating disorder themselves. So there may be something genetic here, there may be something with regards to depression. They also found that they have low levels of serotonin, which is also linked to depression. So looking at those things, this piece is definitely something that cognitive theorists are going to be looking towards, and therapists also will be addressing this when it comes to treatment. We'll talk about that a bit more further on. So moving on to slide 7, we have biological factors behind eating disorders. It's been found that certain genes may leave some particularly susceptible to developing an eating disorder, and they found that relatives of those with an eating disorder are up to 6 times more likely to develop the same disorder themselves. A twin study also found that identical twins with an eating disorder, often one will develop an eating disorder 70% of the time if the other also has the disorder. So huge genetic leaks there. And like I said earlier, low serotonin levels have also been measured to be low in many people with eating disorders. Some people may be genetically predisposed to have lower serotonin levels, which may just increase risk. It might cause them to crave higher carbohydrate foods or display depressive symptoms, otherwise just lead into an eating disorder. Another thing that's important to note is the role of the hypothalamus. This is a part of the brain that regulates many bodily functions, and 2 areas of the hypothalamus in particular help control eating. The lateral hypothalamus produces hunger when activated, and the ventromedial hypothalamus suppresses hunger when activated. And these 2 parts of the brain, along with many hormones and chemicals, help kind of regulate the body's weight. They act as a sort of weight thermostat, which tries to keep the body at a specific weight, which is called a weight set point. This weight set point may be set, for lack of a better word, either in early childhood with early eating habits, or it may also be influenced genetically. But regardless, their body is gonna constantly be trying to keep them at that weight. So somebody with an eating disorder may either be constantly fighting that and making it harder on themselves, increasing stress, or some people may manage to ignore it altogether, which is very dangerous, because at that point they are in full control of their weight, which can be very dangerous when you get to starvation, things like that. That's how many deaths occur. So biological factors are very important to look at. Then moving on to slide 8, social and cultural factors. So it's important to note that women are way more strongly affected by eating disorders than men. 90 to 95% of anorexia and bulimia cases are women, whereas with binge eating disorder, it's more evenly split between men and women. Another important thing to note is that eating disorders are much more common in Western cultures than in other cultures, which just reflects the importance of body image and cultural views on beauty in the development of these disorders. Western culture puts a huge emphasis on being thin and fit and having a low weight. This is reflected by things like over the last 100 years or so, the average weight of models has declined. Athletes in particular face more issues with body image and controlling weight. So the cultural part is very important to note and remember. It's also been seen that, like in people of African descent, they used to have very small incidence of eating disorders in their populations in America, as opposed to Caucasian demographics, where as time has moved on and these demographics have become more acculturated, we've seen that African demographics have seen more incidents of eating disorders to kind of match the Western level. So culture definitely affects this. Another thing to note is that while men don't see as many eating disorders, they are not immune. Men also experience one in particular called muscle dysmorphia, which is kind of like a reverse anorexia, where men may feel like they're too small, they're not muscular enough, and so they constantly work to try and get more muscular despite being perfectly fit. So it's like the same underlying cognitive processes, but just directed in a different direction. And so then finally, the last factor we're going to be looking at on slide number 9 is the family environment of the individual. Families may play a very important role in both the development and maintenance of eating disorders. Families that display an enmeshed family pattern, which is a pattern that leads to a lot of over-involvement and closeness in the family, it may cause people to just overstep their bounds and put severe pressure on family members to stay thin and or underweight. So that's something to watch because it can be very damaging. Some people with poor family relationships may kind of be forced into a sick role, or the role of a sick person, as a way of coping with poor family relations. It kind of pulls people together when somebody's sick, so everybody can band together to try and help this person. So there is a lot of very complicated stuff there. It's looking at family relations is something that when an eating disorder is diagnosed, a therapist or psychologist is definitely going to want to look at family interactions, because it's something that can really keep eating disorders going. Not just causing them, but like maintenance of them, keeping them going. And so that's something to watch for sure and address quickly. So that is the big main factors that lead into eating disorders. We're going to take a little break here. I want to check in on y'all after eating your snacks. Every time I said the, I haven't been keeping track of myself of how many times I've said it. Hopefully it's not too bad, but it's going to get worse. I'm going to be saying a lot of thes here in the second half of the presentation. So after looking at all of these different causes and factors that go into eating disorders and this multi-dimensional approach, we're now going to be transitioning into the treatment of eating disorders. This is going to be tailored to individual disorders and individual people on a very case-by-case basis, but there are also a lot of techniques and practices that all of these eating disorders have in common. So there are some general rules that you can use in treating eating disorders. So we're going to be starting by looking in a bit of a broader sense and then kind of diving into more specific instances of treatment. So first of all, on slide 11 now, we have two major goals of treatment. The first goal is going to be correcting the dangerous eating patterns and behaviors. So anorexia, this is going to be starvation. In bulimia, this is going to be the binging and purging behavior. And in binge eating disorder, it'll just simply be the binging. So the first goal here is going to be just stop these harmful practices and habits. And we're going to go into how this is done in a bit. But the second goal is going to be, after the dangerous eating patterns are addressed, then we can address the psychological and situational causes of the disorder. So we're going to be looking at all those factors we just talked about and trying to treat them one by one using either a physician, a psychiatrist, nutritionalist, in each area of this person's life. It is very multifaceted, and it affects every aspect of a person's life when they have an eating disorder. So that'll be important to look at. So firstly, looking at treatment, we're going to start with how is our proper weight and normal eating patterns restored. So addressing that first goal. So in life-threatening cases of anorexia, sometimes you may see forced tube and intravenous feeding, but what we really prefer to use is going to be like behavioral approaches based on rewarding healthy behavior. So this is what we'll be trying to use whenever possible. And this applies a bit more to anorexia, but it also, you can see it in bulimia and binge eating disorder, is trying to reward proper behavior. A big thing that's going to be a help in dangerous cases is supportive nursing care. So this is going to be not necessarily inpatient, it can be, but this is going to be nursing care that focuses on rehabilitation and restoring proper eating patterns and proper weight in cases of being obese or severely underweight. They found that in a supportive nursing care program, patients usually reach normal weight again in 8 to 12 weeks, which is pretty good. After you've restored that normal eating behavior, then you need to gain all the weight later, and that's a more lengthy process. And once you hit that point, then it's much easier to maintain that routine and maintain that weight throughout treatment. So that is the best way we have discovered right now to restore proper eating in these cases. Moving on to addressing kind of the second goal on slide 13, how are lasting changes achieved? We have two basic methods of this. Firstly is going to be cognitive behavioral therapy, and this is going to be addressing that core pathology at the heart of the disorders, shaping thought patterns away from destructive tendencies. So this may involve using diaries to monitor a patient's feelings and food intake. And this therapy places a large emphasis on recognizing one's need for independence and learning more appropriate ways to be in control. And then also we have changing family interactions. So this is where the family and the social and cultural piece comes in. Professionals may need to meet with the patient's whole family in an attempt to discern any dysfunctional patterns or tendencies that may be affecting the patient. This is something after the mole we could probably get pretty close, I'm guessing. But a therapist is definitely going to be trying to help somebody with anorexia or bulimia learn to separate their own needs from those of their family, learn to place less emphasis on their appearance and others' impressions of them, and kind of making it more individual, trying to gain that individuality, independence, and control. So after treatment is said and done, it is a rather lengthy process. We have a variety of outcomes that can come of this. Moving on to slide 14, we can kind of see the aftermath of anorexia in particular. We see, encouragingly, up to 90% of patients continue to show improvement years after their treatment. However, about 25% remain seriously troubled, struggling with this core pathology and urges to continue starvation. There is also a very large chance of relapse in times of stress. It is a very long process, and it can take years to really get past this. And as many as half of those with anorexia nervosa continue to experience emotional problems such as depression, obsessiveness, and social anxiety, even years after their treatment. So it's definitely something to work out over a long period of time. Interestingly enough, teenagers show better recovery than older patients, probably due to maybe just less experience. It might be due to being more open to new ideas at a younger age. But regardless, it's a lifelong process. It takes a lot to fully recover from anorexia. And this applies a bit to other eating disorders as well. Going to slide 15, looking at bulimia nervosa, it's very similar to that of anorexia. We're going to be utilizing the same techniques, just tailored more specifically to the features of bulimia, so the binging and purging. Behavioral techniques might be used, so we might be keeping track of one's feelings and urges over the course of the day, and then when somebody has an urge, there's a number of tools that you can use to try and address them. One very useful tool is exposure and response prevention, which aims to correct an urge to binge or purge based on behavioral learning techniques. So an example of this might be giving a putting a patient in an environment where there's a lot of stress and then trying to prevent them from engaging in binging behavior, or providing them with a very large meal and then preventing them from engaging in compensatory behaviors. And over time, you kind of build this habit up of not engaging in the damaging behavior. So other things might be useful would be a diary or reporting to a therapist to keep people accountable. Of course, cognitive therapy and interpersonal therapy, like we saw in anorexia. And interesting enough, antidepressant drugs work well in combination with these other forms of treatment in bulimia. It may help up to 40% of patients this way. And after treatment, bulimia nervosa patients, about 40% of them show immediate and stable recovery, while another 40% show moderate response with solid improvement but constant struggle. And then finally, that remaining 20% show little to no improvement. So it is definitely a difficult one to treat well. And it can affect people for a very long period of time. So it's a lot to think about, and we still have a lot to learn about how best to treat these and just show more lasting improvement. So looking finally at treating binge eating disorder. Binge eating disorder was only recognized relatively recently as a disorder by the DSM-5. I don't believe the DSM-4 had this disorder recognized. So it is a bit less established than in other eating disorders, but treatment is mostly the same. We're going to be using many of the same techniques, and we're looking at many of the same causes, just tailored a bit more to bulimia nervosa. One thing that's very important to this is just going to be that behavioral piece and breaking out of these habits. One thing you might see a lot, particularly in binge eating disorder, is trying to condition aversions to food or offering alternatives to kind of sublimate those urges to eat food. So what I've been having you do by eating the snack food the entire time, whenever I say the, is really just to try and get you sick of this food. Hopefully it worked well. I don't remember how many thes I said, but you should hopefully be a bit sick of whatever you've been eating this whole time. You may have had to pause the video to have time to eat everything. But hopefully you feel a little bit maybe of what it's like to experience a binge, and then just the kind of the grossness and the fullness and maybe a little bit of the guilt that many patients experience after an eating binge like this. As well, if we were to keep this on for a long period of time, if I were to sit here and talk to you for the entire class period, for example, you may actually condition a real aversion to the food. Food aversions are very easy to condition. It may only take getting food poisoning once to hate a food, but if you eat a whole lot of food in a short period of time, you may just have a really bad memory associated with it, and because of that, you may just hate the food. So one thing that sometimes they'll use to treat binge eating disorder is condition aversions to these people's favorite food and try and keep it undesirable. Find other things to do with these urges when you get stressed or you feel like you need to eat. So hopefully you were able to experience a little bit of that. I guess we'll see how it goes being kind of an at-home format, but this is also something you could just try any time of any day. If you wanted to play a sort of drinking game with yourself with a snack food, just say, oh, every time I hear somebody cough or sneeze, I'm going to eat one of these, and then see what you can do. Maybe if you tried it over a couple of days, you could honestly condition a real food aversion in yourself and hate the food. So definitely don't do this with the food you like, but it's a really interesting phenomenon, and hopefully it was able to give you guys a glimpse into what a binge eating disorder might feel like at times, maybe just a little bit. But regardless there, moving on to the next slide, that is about all I have. We looked at the causes and many factors that go into eating disorders. We looked at how treatment then is tailored around these different causes, how treatment has two main goals, addressing the behavior and then addressing the causes. They are very separate, and so it will definitely probably you may need 3 people to kind of treat this disorder. You may need a physician, a psychologist, and a nutritionalist to address all of the different facets of it. There is a lot that goes into these disorders, and there's certainly a lot packed into these slides. I know hopefully you have the freedom and time to kind of pause and go through each of these slides to read all of that. There is a lot to cover in this chapter, and eating disorders cover a wide category. But hopefully I was able to give you a pretty quick crash course, and you have the opportunity to read the book, and so the test should be pretty good, pretty easy. So thank you very much. That is all I have for you today. Hopefully the experience was fun for you, and hopefully you don't hate the snack food too much, or maybe you'll get over it quickly. But with that, thank you very much. That is all.